A 32-year-old woman presents with generalized weakness and paresthesia. Her blood pressure is 155 over 100. Lab studies show low plasma renin activity. CT scan shows a 1.3 centimeter right adrenal mass. Which of the following patterns of serum electrolyte concentrations will most likely be seen in this patient? Now, this patient is presenting with generalized weakness and paresthesia. This indicates an electrolyte abnormality or a acid-base disorder. Her blood pressure is elevated, and in a young patient, this is most likely going to be a secondary cause. And the patient also has low plasma renin activity, and these findings are all consistent with primary hyperaldosteronism. Remember that aldosterone will have a negative feedback on renin. As a result, we'll have low plasma renin activity in hyperaldosteronism. Now, the CT scan shows a adrenal mass, and the most common cause of primary hyperaldosteronism is going to be adrenal adenoma, also known as Conn's syndrome. Remember that it can also be caused by bilateral adrenal hyperplasia, but an adrenal mass is mostly going to be a unilateral mass, and this patient only has a mass on the right adrenal gland. Now, in terms of serum electrolyte levels, remember that aldosterone is going to have multiple effects on the collecting tubule of the kidney. Now, on the principal cell, aldosterone is going to stimulate the sodium potassium pump. So it's going to reabsorb sodium and put more potassium into the principal cell. And aldosterone is also going to stimulate the sodium and potassium channels on the apical side of the principal cell. And so we're going to be reabsorbing sodium and excreting out potassium. So we will ultimately have low potassium levels. So we can cross out answer choices C and D. Now let's focus on bicarbonate levels. Remember that aldosterone is going to stimulate the hydrogen ATPase found on the apical side of the alpha intercalated cell. So as a result, we were going to be excreting out protons into the lumen, and this in return is going to increase the activity of the bicarbonate chloride exchanger found on the basolateral side of the alpha intercalated cell. So we're going to be reabsorbing more bicarbonate. And so our bicarbonate levels are going to be high. So we can cross out answer choice E. Now, answer choice E was the most common answer choice picked by students because they probably saw that sodium was high in this answer choice and went with it. But remember that aldosterone, although it is going to cause reabsorption of sodium, we have a mechanism in our body called aldosterone escape that is going to diminish the activity of aldosterone when our body is in a state of hyperaldosteronism. And so our sodium levels are actually going to be normal. So the answer to this question is going to be answer choice B. Now let's go over what aldosterone escape is because this is a high yield concept. So remember that aldosterone, we said, was going to cause reabsorption of sodium, and water is going to follow sodium, and that will in return lead to hypertension. When we have hypertension, the atrium is going to release a hormone called AMP, and AMP is going to cause an increase in GFR by constricting the afferent arteriole and dilating the afferent arteriole. And this increase in GFR is going to cause excretion of sodium and water. And so that is in return going to diminish the hypernatremic and the hypertensive effects of aldosterone. And that is why in this patient, sodium levels are going to be normal and not high, because it is going to be caused by this aldosterone escape mechanism found within our body to protect us from high aldosterone levels. So again, this is a really good summary from UWorld on why aldosterone escape is going to cause more sodium excretion, leading the patient to have normal sodium levels instead of high sodium levels.